Rohit, Dr. Rohit.
मैनेजमेंट ऑफ स्ट्रीमिंग
हाँ ये ले लीजिए, इनवाइट कर लीजिए बाकायदे.
I invite Dr. Rohit Tiwari, management of STEMI in 2025 key takeaways.
Uh, Good afternoon. First of all, I would like to thank Alok. He's been brilliantly organizing this for more than a decade, and he deserves a standing ovation. The topic he's allotted me is management of ST elevation MI. A lot of this is the conundrums in management of MI, and in this, I'm not just talking about the management on table. It is lipids which keep bothering us, and they have been very nicely dealt with in the previous talk. So, acute MI, as we know, is commonly called as heart attack, is irreversible necrosis of the muscle secondary to prolonged ischemia. The imbalance between oxygen supply and demand caused by plaque rupture, thrombus formation, resulting in acute reduction in blood supply to a portion of myocardium. Uh, it is very, very frequent, 1 in 6. Approximately every 34 seconds, there is a coronary event, so it is as frequent as that. You can see it is a male dominated epidemiology. Myocardial infarction in all the age groups, we see men are largely affected. Uh, and in this, it is important to know that as Indians, we are actually the very prone, genetically, we are very prone to ACS wherever we live. Incidence by the decade, risk factors, lifestyle, diet, as we've been talking of, tobacco, excess alcohol consumption. Now, it is important to know there is a perception कि शराब पीने से we don't get we are saved from heart disease. So 30 ml saves you, and anything above 60 ml increases your risk. So this is very important to tell your patients कि शराब आपको बचाती है as long as it is less than 30 ml. More than that, you are increasing your risk. Elevated blood pressure, LDL, low plasma HDL, elevated triglycerides have also come into the forefront. Diabetes, as we all know, obesity, and thrombogenic factors. Personal characteristics that are not modifiable: age, sex, family history, and personal history of other atherosclerotic disease. Now, increasing age and male sex. Above 45, you have 8 times higher risk of heart attack. Even after menopause, the rate of death starts to rise in women. Hypertension, dyslipidemia, and diabetes, we've already talked about all that. Smoking increases a person's risk 4 times above non smokers. Obesity, physical inactivity, excess body fat, lack of exercise, we all know all this. And as I was coming to this, uh, binge drinking, alcohol drinking, 3 or 4 drinks increases the risk of heart attacks. So this is something that is important to pass on to your patients. Uh, Coronary artery occlusion, we've been reading this from the second MBBS onward. We know the pathology and pathophysiology of MI, exposure of subendothelial collagen, plaque deposition, platelet adhesion. Uh, So apart from that, vasospasm, emboli, and other vasculitis, amyloid, vascular dissection, aortic stenosis, these cause imbalance between supply and demand. The myocardial response, coronary artery obstruction diminishes blood flow. ATP depletion, loss of contractility, and then eventually irreversible injury. Now, classification: transmural versus subendocardial. We all know that ST elevation, non-ST elevation. My job is to talk about the ST elevation. So this, the above, the arrow is the ST elevation MI, and this is the non-ST elevation MI. There is a new classification type 1 to 5 caused by atherothrombosis type 1. Type 2 is imbalance between oxygen supply and demand because of atherothrombosis. Third is cardiac death, where there are electrocardiographic changes of arrhythmia. Fourth is peri-PCI, and fifth is peri-CABGMI. Signs and symptoms, we know this Levine's signs, sensation of heaviness, squeezing, pain radiating to the left arm. And silent MI, 20 to 30% of your patients will not have any symptoms whatsoever. Nausea, vomiting, shortness of breath, diaphoresis. There is a massive surge in catecholamines, therefore you have a lot of sweating, lightheadedness, palpitations, loss of consciousness, and sudden death. ECG changes, we know ST elevation. Rise in biomarkers, myoglobin and troponins. I always recommend quantitative troponins over the card tests. The management overview, morphine, oxygen, NTG for pain management, aspirin, clopidogrel and beta blockers, early hospital therapy, ACE inhibitors, non-dihydropyridine calcium channel blockers, fibrinolytics, and PCI, in some cases CABG or laser revascularization, which is very, very limited. Now, recent guidelines, I went through the recent guidelines on what do they say. The first thing was that oxygen helps only if your patient has an SpO2 less than 90. So you don't have to give oxygen otherwise. If your patient is maintaining normal saturations, you do not benefit as such from oxygen. Preferred loading is now quite clearly ticagrelor, in some patients prasugrel in the young. Clopidogrel I use selectively, but cost-wise, of course, clopidogrel is good. In what you can do is you can give a month of ticagrelor and then you can switch on to clopidogrel. IV only cangrelor is approved. In IV GP2B3A inhibitors, they are not class 1 now, they are class 2A. They are recommended only if your thrombus load is high. So there is a user discretion in this. It is not useful routinely. Lipid management, you have to go by the high intensity as per guidelines that was so nicely dealt with in the previous lecture. Beta blockers seem to be underused now. Beta blockers are class 1 in acute MI. Beta blockers have fallen into disrepute, and over the last 3-4 years, we've been seeing very less usage of beta blockers, but I am a beta blocker supporter. I feel they are useful. Of course, you need to know which patients to use in. They should not be in frank failure. And RAS inhibitors, yes, if you can put your patient early on RAS inhibitors, I still feel ACE inhibitors are a little better over ARBs in this. Analgesic therapy, this is also from the guidelines. NTG, we know we can use sublingual or intravenous. Morphine, 2 to 4 milligrams, repeat. Doses may go up to 10 to 15 milligrams as the case may be. Fentanyl, 25 to 50 micrograms. You can repeat. A maximum of 100 can be considered. All these are for pain relief. Non-statin treatment goals, statin is discussed. Non-statin, we can use ezetimibe, we can use these monoclonal antibodies. Inclisiran, this is very costly, so I have not been able to persuade any of my patients. Bempedoic acid, yes, in a few, in the statin intolerant. Dosing of parenteral anticoagulation, unfractionated heparin also I use quite a lot because of cost considerations in my PCI patients. Bivalirudin very infrequently, enoxaparin, and yes, I do use a lot of enoxaparin. Prevention, smoking cessation, moderation of alcohol, physical activity, encourage your patient to exercise at least 30 minutes and try to lose just 10% of his current weight. We can't give them ideal targets, but small targets and encourage them to move on from there. Diet modification, diet rich in fiber, vegetables, fruits, lipid management has been extensively dealt with. You have to lower the saturated fat, increase the viscous fiber, and use omega-3 for those who are non-vegetarian. Those who consume fish, you can encourage them to take fish. Control comorbidity. Hypertension has to be looked at very nicely. Diabetes control has to be very aggressive. Try to target your HbA1c below 7. Patient education involving the family. Now, I'll just show one case. This patient, I also go to different areas of India to do cases. This I went to Aizawl, where the geographical condition did not permit me any other help, right? So this is very recently I did this. A very octogenarian 82-year-old man who had liver disease, brought to the emergency in cardiogenic shock, BP 60, heart rate 38, complete heart block, had collapsed at home 2 hours back. ECG showed ST elevation MI with complete heart block. Immediately we shifted him, we explained to the family, shifted to the cath lab. There's a huge thrombus, which I tried everything. I'll just show the slides. I tried everything. I tried thrombosuction. I tried dilating with a balloon, but we could do nothing to that thrombus. Eventually, I tried something that we used to do in escorts. I put the guide inside, and with the guide catheter, and I directly sucked the thrombus, and I was lucky to get that stuck between the guide and and I was able to pull everything out with the guide, and the thrombus came out, and I got a beautiful flow. And that patient got such a nice result, I did not have to put any stent. So no dual antiplatelet needed. I was able to manage immediately. Hemodynamics improved. So I'll just show that patient. This is the left system. This is the LAD. It was fine. And RC, it was very difficult because of a lot of tortuosity, and I did not have anything. I did not even have a long sheath. The long sheath that I used, my catheter was not reaching. Eventually, I had to remove the long sheath. Somehow, I was able to negotiate and reach. Now, you see, the flow is very nice, but that is when I deep seat the catheter. This is a Judkins that I was deep seat, and proximally, there is no backflow. So, there is a huge chunk of thrombus over here. Now, what I did, I sucked out with my guide, and perfect TIMI3 flow. There is no proximal dissection, and I managed the patient. I was very happy that I did not have to put a stent, so I did not have to bother about whether he will need dual antiplatelet, what to do. He had liver dysfunction, so bleeding risks were always playing on my mind. And the patient recovered. By evening, we could remove his TPI, and so I was quite happy with that. Thank you.
Regarding the loading dose, in one of your slides you said that prasugrel or ticagrelor. So this is for PCI patient, I think. For non-PCI patient like thrombolytic therapy.
You can easily stay put with the clopidogrel. That is quite a nice.
Okay. For I think for thrombolytic therapy and for non-PCI patients, we have to give clopidogrel instead of.
I feel a lot of thrombolysis is beyond the window period. So there it's very debatable. Very few patients actually reach to us within the window period. We have to be lucky. But in those patients who are not able to afford, where you are not planning any intervention, then clopidogrel is a very reasonable alternative. But if you start these patients also on prasugrel or on ticagrelor, there is no harm if they can afford. It is not contraindicated. It's not that if you are not doing PCI, so you cannot use ticagrelor. You can use it. It's completely
okay. But with thrombolytic therapy, I think it is not recommended. If we are thrombolizing the patients, then we have to give clopidogrel only rather than ticagrelor or prasugrel.
It is debatable. It is debatable. Basically, it is the cost actually. In India, it is the cost that plays.
So thanks for sharing your last case, which was a very interesting, well managed. I mean, in a very different way. You told that you have 2 such cases. I mean, the second one, would you like to share? You have shared one in the slide, and
I don't have the slides, otherwise
Okay.
it actually is not interesting if you don't show the slides. I have done quite a lot of work in this thrombus based thing. I have, that is not, I'll show you some other time, where I put a covered stent. We don't get that covered stent anymore. At that time I was in Medanta, and we had some tie-up with, in a study with Israel. And we used a special covered stent, and those results were marvelous. Those for thrombus, it was excellent results. So sometime I'll show you those cases. They are very nice. It's very interesting to see those cases.
thank you
We don't
very
get
much.
that. Somehow that study also fell off, and I don't know why. Our results were excellent. But if that would have come into clinical practice, I was very, very impressed with the results and outcomes in that.
Thank you, sir. Any more question? So it's my privilege. Thank you so much, Dr. Rohit
Thank
Tiwari.
you.